Hello, and welcome to the Gastrointestinal Lecture Series. My name is Katie Lee Huang, and I'll be helping you review the GI system. There's quite a bit of material here to discuss, so let's get started and jump right in with a review of embryology to give us the background we need before moving into the anatomy, physiology, and pathology of the GI tract. Let's begin with embryology and look at how the GI tract forms. The primitive gut can be divided into the foregut, the midgut, and the hindgut, with each segment of these giving rise to specific gut and gut-related structures later in development. Luckily, these structures correlate well with the position of the embryonic structures. First, the foregut contains the structures from the pharynx to the duodenum, which you can see here in orange. Next, the midgut is from the duodenum to the transverse colon, which you can see here in purple. Finally, the hindgut is from the last third of the transverse colon to the rectum, which you can see here in green. The blood vessels that supply these structures are the same throughout development, so you really only need to learn them once. At week 6, the midgut undergoes rapid growth and herniates through the umbilical ring, since the fetus cannot yet accommodate the size of the midgut. At week 10, the abdominal cavity enlarges and the midgut is able to return. But when it does this, it rotates 270 degrees around the superior mesenteric artery. The GI organs are now in their adult positions, which you can see here on the right. Let's do a quick flash quiz now to cement our learning. The midgut of a newborn with severe abdominal distension is found to be malrotated around the blank artery. Which artery is this? That's right, it's the superior mesenteric artery, and this is important to remember. Interesting pathologies can also result when there are developmental defects. There are a number of developmental defects of the anterior abdominal wall. Let's now go over some of the pathologies that you can see in GI embryology. Interesting pathologies can result when there are developmental defects. There are a number of developmental defects of the anterior abdominal wall. Let's go over some examples of anterior abdominal wall defects in this table. First, rostral fold closure results in sternal defects. Second, incomplete lateral fold closure can result in omphalocele and gastroschisis, which we will discuss more in a moment. Lastly, inappropriate caudal fold closure results in bladder exstrophy with part of the bladder outside the abdominal wall. Let's now talk about gastroschisis and omphalocele. So what is gastroschisis? Gastroschisis occurs when the abdominal contents extrude through abdominal folds and are not covered by the peritoneum. In contrast, omphalocele is when the abdominal content herniates into the umbilical cord, as seen in this image. The abdominal contents are covered by peritoneum. Let's go over a few more important developmental defects. Duodenal atresia is where the bowel fails to recanalize. Do you remember which chromosomal abnormality it is associated with? That's right, it's associated with trisomy 21. On abdominal radiograph, you can see a double bubble sign, as you can see here on the right, which is due to dilation of the stomach and proximal duodenum. Here you can see where the normal bubble would be from the stomach, but here is the second bubble. Jejunal, ileal, or colonic atresia is due to a vascular accident during development, leading to ischemia and narrowing or obliteration of the affected area. This results in an apple peel appearance of the bowel and is called an apple peel atresia. Next, let's go over tracheoesophageal fistula. A tracheoesophageal fistula is exactly as it sounds like, an abnormal connection between the esophagus and the trachea. There are many different permutations of this. First, there is the most common subtype, a blind upper esophagus and a lower esophagus that is connected to the trachea, which you can see here. Here, the esophagus is connected to the trachea, whereas the proximal part is blind and has no connection. This is called type C. There is also type A. This is where there's a proximal and distal esophagus, but no middle part. There can also be, as you guessed, type B. This is where the proximal esophagus connects to the trachea, but the distal esophagus is by itself. Finally, type D is where both the proximal and the distal esophagus connect to the trachea. The clinical presentation of tracheoesophageal fistula is quite striking, and once diagnosed, prompt surgery is required. Tracheoesophageal fistula can cause cyanosis, an air bubble on X-ray of the chest, and pneumonitis due to the upper esophagus being connected to the trachea. Other features also include choking and vomiting with feeding, and failure to pass an NG tube into the stomach. Finally, tracheoesophageal fistula can cause polyhydramnios, which is excess amniotic fluid in the amniotic sac due to the infant's inability to drink. Okay, let's next talk about congenital pyloric stenosis. Congenital pyloric stenosis occurs when there is a narrowing of the opening from the stomach to the intestine as a result of hypertrophy of the pylorus. This occurs at the region of the stomach connecting to the duodenum, which you could see here on the image, and this causes an obstruction. On physical exam, the hypertrophic pylorus is often palpable, and this is commonly called an olive mass. This also presents in the first 2 weeks of life. Since food can't pass into the intestine and the stomach is trying to squeeze the food into there, this force causes projectile vomiting. However, since it never makes it to the intestine, it's non-bilious. Here we can see an ultrasound of a 5-week-old boy with non-bilious projectile vomiting. And here you can see this increased pylorus. Okay, let's continue along the GI system. The pancreas is derived from the foregut, and hence it is endodermal in origin. Pancreatic development begins with the formation of the ventral and dorsal buds, which you can see here. The ventral bud becomes the head and the uncinate process, whereas the dorsal bud becomes everything else, including the body, the tail, isthmus, and accessory pancreatic duct. The spleen, on the other hand, is not derived from the foregut, but is derived from the dorsal mesentery. It is, however, supplied by an artery of the foregut, the celiac. When the ventral pancreatic bud encircles the second part of the duodenum, this forms what is called an annular pancreas, and this encircling can result in duodenal narrowing, which you can see here. Finally, pancreas divisum occurs when the ventral and dorsal buds fail to fuse, leading to exactly what it sounds like, a divided pancreas. Congrats! You've now made it through the embryology section. Let's now do a review question to solidify all that you've learned. So you're in the emergency department, and a 5-day-old boy is brought in because of vomiting and constipation. His vomitus is greenish in color. The infant's abdomen is markedly distended and dull to percussion. The infant's condition most likely can be attributed to a deficit in which of the following embryologic cell populations? Is this from the endoderm, the mesoderm, the neural crest, neuroectoderm, or the surface ectoderm? The correct answer is C, neural crest. Let's go through this, as this is a classic question on the boards. First thing to note is the age of the boy, since on an embryology questions, this can help clue us in into what might be going on. Is it early in life, suggesting a developmental process, or it's something that has developed over time? Well, since he's a 5-day-old boy, it seems to be a developmental process. Next, let's tackle the bilious vomiting and the constipation. Bilious vomiting suggests there is no obstruction proximal to the pylorus. If the patient had projectile vomiting, what should we expect? Well, that's right, pyloric stenosis. But our patient has bilious vomiting and constipation. The constipation is a sign that the GI motility is not sufficient, giving rise to the extended and dull percussion. So, this is Hirschsprung's disease. What's Hirschsprung's? Hirschsprung's is a congenital condition caused by a failure of the neural crest cell migration to a distal portion of the abdomen, so the correct answer is C. We didn't go over this directly in what we just learned, but I wanted to use this as an example of how you can use things that you've learned to help deduce the right answer as well. This ends the end of embryology, and let's move on next to anatomy.